Okay, good evening, everyone. Welcome to our fourth and final training event of spring 2022. I'm Julie Tennille, Project Director for EPIC. As always, I'd like to express my gratitude to the team behind the scenes, and this includes, of course, Wendy Myers, our Program Coordinator, Fatima Bakayoko, our Graduate Assistant, Sarah Fisher, our Research Assistant, and Dr. Cheryl Neal McFall, our Program Evaluator for EPIC. We are very excited about our presenters tonight, and we'll introduce them momentarily. Okay, let me tell you about our wonderful presenters. Dr. Roger Harrison is a pediatric psychologist. He is also a diversity and inclusion educator at the Office of Health Equity and Inclusion at Nemours Children's Health in Wilmington, Delaware, and clinical associate professor of pediatrics, Sidney Kimmel College at Thomas Jefferson University. Dr. Lonna Gordon is Chief of Adolescent Medicine, Director of Diversity, Equity, and Inclusion for Graduate Medical Education at Nemours Children's Health in Orlando, Florida, and Assistant Professor in Pediatrics at the University of Central Florida College of Medicine. We are so grateful to have you two tonight, and we look forward to your presentation. So I will stop sharing my slides and mute myself and allow you to share yours and get your amazing presentation underway.
And it is a pleasure to be here with all of you. Again, my name is Roger Harrison. I'm going to go right away to answer a question someone asked. What is an integrated setting? So I'm an integrated primary psychologist, meaning that I work alongside pediatricians in the pediatric office. That is where I set up. We work together as an integrated team with psychologists, pediatricians, social workers, breastfeeding coordinators, nurses, nurse staff, and it just means that multiple professions working together as a team to enhance and make patient care better. And so, Dr. Gordon, go ahead and introduce yourself. I get my slide up. I'll get the presentation right on up.
Yes, and I am an adolescent medicine specialist, and I know sometimes people ask me, what does an adolescent medicine specialist do? And I frequently say that we are pediatricians who specialized in an age. So loosely, that's considered 10 to 25 in most locales. And that we take care of anything that could affect a teenager. And so, well, how does an adolescent specialist differ from a general pediatrician? And so I would say it's because we specialize in risk. And so I always say to, to people that in a lot of ways, I'm a doctor who specialized in risk. So to some young people, I look like a reproductive health doctor. To other people, young people, I look like a doctor who takes care of eating disorders. To others, I'm a person who looks very similar to a mental health professional. So it really depends on what is the risk that young person is experiencing. And so I frequently have worked in integrated settings, but also in my current practice model that I have right now, I have an integrated social worker, but then I have a lot of community partnerships as well, where my patients may receive, their mental health care or other aspects of their care, and then we'll conference usually on a weekly or biweekly basis.
Great, thank you. So we're going to jump right in. There's a lot. Frankly, we over-prepared for the time that we have. But I want to start by saying this is a workshop where it's the workshop. We're going to be talking about suicide. And it does include some vignettes that contain specific details about suicidal behavior in young people. And in a room of almost 400 people, we expect that people will have had personal experience with that. And so the first thing that we want to say is, if you are someone you know is experiencing any kind of crisis, there are lots of ways to reach out, including the Suicide Prevention Lifeline, which you can use your QR code to access. You could text HOME to 741-741, and Congress just passed the National 988 legislation, and now it's only up to states and localities to ensure that, like 911, we have a 988 line that people who are experiencing crisis can access. All right, we're going to ask you some questions, all related to suicide. So first question is this: true or false? Suicide is a first world adolescent problem and young adult problem. True or false? Is this true? Is this false? Just give your answer. All right, so what we see is that 173 of you have got that right. Lonna, the answer is, help them, please.
I unmute myself. The answer is absolutely false. It is not just a first world young adult issue. And so a lot of times, people do think about suicide as being a young adult concern, but we recognize that that is actually not true. According to the World Health Organization, suicide is is something that is common across all of the continents, and its highest rates are actually seen in Southeast Asia and Europe, then followed by Africa and then the Americas. So I think sometimes we have a view that we are kind of centered in what's happening in the world in healthcare, but this is not an area where we are centered. And so as a result, no, suicide is actually quite prevalent in other locations.
All over the world. All right, let's move on to the second question here. According to the CDC, how many suicide attempts are there per year in the United States? Would you say 120,000, 1.2 million, 12.2 million, or 3.2 million? Lock an answer. You have about 8 seconds to, if you're not sure, it's okay. That's what the Kahoot is for. And that's why we're here tonight. How many suicide attempts per year? So 103 of you got it right. According to the CDC, using 2019 data, about 1.2 million attempts, although 12.2 million people considered suicide and 3.2 million made a plan, but did not continue. So we have Amber P currently in the lead and a whole lot of people right behind her, but go as fast as you can. We'll ask the next question. So what age and gender demographic would you say had the highest rate of suicide in America in 2019? What would you say? Males 45 to 64, females 45 to 64, males 75 and older, or males 15 to 24? Who had the highest rate of suicide in 2019? Well, the 15 of you got it. And so Lonna, you want 30 seconds to give them tell them a little bit about that.
So, a lot of times we think about, middle-aged adults as accounting for about 47% of all suicides, but older adults actually account for fewer than 10% of the completed suicides, despite having the highest rate of suicides. So a lot of times we think of this as being a young adult problem, but actually, there are so many risk factors that really make older adults quite vulnerable and quite likely to have some of the highest rates, even if they're not the highest completion rates.
Absolutely. Men over 75, by far the highest rates of suicide. So next question, which age demographic accounted for the highest number of suicides in 2019? Would you say middle-aged adults had the highest number? Young adults, 25 to 34, had the highest number. Older adults had the highest number, or youth, 10 to 24, had the highest number, not the rates, just the raw number of suicides in 2019? Well, 69 of you identified that correctly. Even though older adults have the highest rate, the per capita, middle-aged adults accounted for almost half of the suicides in America in 2019. And those 10 through 24 accounted for 14% of suicides in 2019. And let's see, Meredith dropped, Stephanie holds, Gen B, welcome to the top. We have 14 of these. All right, we're gonna move quickly. True or false? Most firearm deaths are due to homicide. True or false? Most firearm deaths are due to homicide. Absolutely false. Go ahead, Lonna.
So yeah,
Gen B.
so I was going to say 60% of firearm deaths are related to suicide. And about half of them happen because of suicide.
Yeah, an incredible amount of firearm deaths are not homicide, but suicide. Next question. Which of the following statements is true about suicide and gender? Women attempt and complete more suicide than men. Men attempt and complete more suicide than women. Men attempt more, but women complete more suicides. Or would you say women attempt more, but men complete more suicides? What is the relationship between suicide and gender? Oh, we have scholars. 140 of you have gotten that right. Men account for about 76% of suicides annually, even though women account for roughly 75% of suicide attempts. And so mostly, well, I won't give it away because I have another question. Men year over year account for around 3/4 of the completed suicides in America. So that puts, who do we have here? You know, Gen B has no interest in going anywhere, and neither does Stephanie B. They want to let you know that they are experts in this. So what was the leading cause of death by suicide for females in 2019? Would you say it was poisoning, firearms, suffocation, or some other cause? Poisoning, firearm, suffocation, or some other cause? Leading cause of death for females. Correct answer, firearm. And I think we could just move on to,
yeah, I was going to say the next one.
Gen B and Stephanie have no interest in moving from the top of this pile. So what was the leading cause of death for suicide by males in 2019? Poisoning, firearm, suffocation, or some other cause? Poisoning, firearm, suffocation, some other cause. Absolutely. So for males who committed suicide, firearms accounted for about 55.6%, whereas for women, firearms accounted for about 31.4%, followed closely behind by poisoning, which for women was 29%, and for men, 28%. But we see some real gender differences where men clearly are utilizing more lethal means when they die by suicide. Gen B, Stephanie, Casey, and Josie really have no interest in moving from the top of this pile. So what race and ethnicity has the highest rate of suicide in America? Non-Hispanic whites, non-Hispanic blacks, non-Hispanic American Indian and Alaska Natives, or Hispanics? Which of these demographics has the highest rate of suicide in America? Wow, a lot of folks thought non-Hispanic whites. Lonna?
Yeah, so, this is one of those areas where sometimes disparity is not evident in popular culture. And so it's actually members of the indigenous community with a rate of 23.9 per 100,000 as compared to non-Hispanic whites at 16.9. So you can see that's a significant difference between those two groups.
Yeah. Oh, enter Collier.
Enter a new person.
Enter Collier. But Gen B, Stephanie, and Casey, they don't have any interest in going too far. So again, we have 14 of these questions. We're moving quickly. This one is for double points. You have to move these rankings up and down on your device. Rank the following causes of death in order. Move them up and down: homicide, unintentional injury, suicide, and then all cancers.
And this is looking at deaths of young people.
Yep, looking for deaths of young people. The top cause of death, put it at the top, and the fourth cause, put it at the bottom. You have about 9 seconds. If you're not sure, just arrange it the best that you can. 26 people got that right. Unintentional injury. Suicide is the second leading cause of death for young people ages 15 to 24 using 2019 data. Remarkable public health challenge that we're going to explore and talk a little bit more about. Whoa, a big shifting, but Stephanie, Casey, and Katie, Lindsay hasn't been seen. We have Ann down there as the highest climber. 4 more questions to go. In which part of the country is youth suicide the most common? The Mountain West, the Northeast, Alaska, or the Northwest? In what part of the country is suicide most common? 83 of you correctly identified Alaska. Lonna?
I was going to say, it must be the lack of sun.
Indeed, the Northeast.
But yes, after Alaska, then we moved to the Mountain West, and the Midwest as being the next higher areas. And then the Mid-Atlantic area actually has the lowest rate nationally.
So props to you who are in the Mid-Atlantic region. KCB, Stephanie, Katie, and Lindsay. Next question. Suicide rates for youth have sharply increased over the past several years. Is this true or false? The suicide rate for youth, those 10 to 24, has sharply increased over the last several years. 177 of you got that correct. In fact, the suicide rate remained stable between 2000 and 2007, and then shot up 57% between 2007 and 2018. Remarkable increase in the rates of suicide. Stephanie and Casey really just, they're just neck and neck, just very, very close. Next question. Since 2018, there's been a continued increase in suicide rates for youth of all races and ethnicities. Is this true or false? It's not true. Lonna, explain why.
It is actually false. So interestingly, we've seen a decrease in suicide rates in people who are of Caucasian as well as Native descent. But we've actually seen a 47% increase in Black males. We've seen a 40% increase in Asian and Pacific Islander males, 59% in Black females, and 42% in Asian and Pacific Islander females. So actually the group that has had the highest increase are Black female adolescents.
Yeah, and the only 2 demographic groups that have increased since 2018, and the CDC just put out the raw data from their Wonder database for the 2021 data that they have. And so it looks like 2019 and 2020 rather, Blacks and Asians were the only demographic groups who showed an increase in suicide rates. All other groups either remained stable or decreased. M, welcome M. Last question. True or false? LGBT and non-LGBT high school students have approximately equal rates of suicide attempts. Absolutely false. Absolutely false. Not even close. 23.4% of LGBT students reported a suicide attempt per CDC data in the past 12 months, where only 6.4% of non-LGBT students. The rates are even higher when we don't ask about identity, but ask who you had sexual contact with. Those who've had sexual contact with both sexes, 54.2% of them reported seriously considering suicide. Those who've only had one sex contact, 19.4, and those who have had only heterosexual contact, 14.5 of them reported having seriously considered suicide. And so we know that for LGBTQ youth and for young people who have sex with more than one gender, the rates of suicide consideration and attempt are quite high. And so that brings us here. Katie, well done. Casey, well done. And who is it? Stephanie, you really hung in there like a champion. Another Katie and M, you clearly have been doing your research. We appreciate this. All of this information that we just shared with you will be available in the PowerPoint deck that will be shared with you. We didn't want to share it with you before, but now that we're done, we can share it with you. And we will, we include all the data as well as the sources for those of you who want to look deeper into the sources to understand this information. All right, so we're going to
jump into some of the didactics of the information. And so first of all, we want to make sure that we all have the same language. And so one of the things that we're going to do to do that is to kind of think about some of the terms. So, you know, a lot of times people will talk about terms like suicide attempt, suicide gesture, and, you know, those terms are a little bit ambiguous at times. So we want to make sure that, first of all, we all recognize that suicide is a death that was caused by self-directed injurious behavior, and there was an intent to die. A suicide attempt proved to be non-fatal, and then non-suicidal self-injurious behavior refers to the act of cutting or injuring oneself without any intent to die. The way that I frequently explain this to my learners and also to parents is that it kind of gets back to the intentionality of the action. So a person who has performed a non-suicidal self-injurious behavior, as well as a person who has performed a suicide, both are people who are in pain and desire for that pain to end. For a person who is thinking about suicide, it is usually that they see the end as being, you know, removal from this, you know, from being in the situation. Whereas for someone with NSSI, it is around kind of being able to feel emotional connection in the situation. So usually the difference of trying to escape some numbness. It's also really important as we think about language. Language matters. And so we want to make sure that we're using inclusive language, both in our descriptions and our discussions. And so the APA has a guideline on inclusive language. These are some of the terms that we pulled out of there that we think are really important in thinking about the context of this particular talk, but definitely, you know, at your leisure, going through that entire QR code is important. A few things of prominence are, one, making sure that we're always using person first identity. So, you know, we don't want to say, you know, a homeless person, but instead a person without housing. We don't want to say, you know, someone who, you know, is a victim. We want to say instead someone who's experienced a particular event or has been impacted by a particular event. So person first language is really important to recognize that people are much broader than the conditions that they may present with. When we're thinking about also thinking about just other terms in that same special needs identity. So, you know, we never want to say things like someone with special needs, physically challenged, mentally challenged, handy capable, so forth. Instead, a person with a disability, a disabled person, a person with an intellectual disability. You know, thinking about mental illness, we don't want to say someone who's mentally ill, but instead a person with mental illness, a person with a mental disorder, a person with a mental health condition. We certainly don't want to use words that are considered a lot more pejorative, like defective, crazy, or nuts. And then same thing, you know, not an addict or, you know, an alcoholic, but a person who has an alcohol use disorder or a substance use disorder. And then we also want to make sure that we're, you know, using, you know, suicide inclusive language that actually defines what, you know, we're actually saying is what happened. So we want to say, instead of someone who committed suicide, failed, or was successful at suicide, completed suicide, instead we want to say a person died by suicide, because suicide is a cause of death.
Absolutely. We don't want to frame it as a crime or an achievement. So just be mindful. And when you look at the slide deck, we'll also have the resources if you don't have the APA inclusive language guidelines. All right, so we're going to spend a little bit of time talking about the way that we assess suicide risk. And the context is that, like most human behavior, there's never a single determining factor in suicide behavior. We know that suicide happens in response to a number of influences, but these are interacting influences, and they're rarely in a moment. These are interactions that happen over time. But we know that when we're thinking about young people, that transition from ideation, from suicidal thinking to suicidal action is often an impulsive act. And it's often for young people an impulsive act that is a reaction to acute stressors. And this is why it is so important that we consider the means because availability of means when I'm having a suicidal crisis is one of the biggest factors that determines the dangerousness or the lethality of the suicide attempt.
And so when we think about that, we think of people as recognizing that people are not just individuals, but people are actually impacted by many layers of events, circumstances, and determinants around them. So we have individual level factors, we have relationship level factors, we have community level factors, and we have societal level factors. And so this model becomes very important because as we think about how do we intervene, how do we recognize, and how do we prevent, we have to take into account all of these different layers. So when we're thinking about individual level factors, thinking about individuals' identities, do people have multiple marginalized identities? That's going to increase risk. Is there a personal risk of struggling with a mental health concern or illness? What is that individual's coping abilities? What is that individual's leaning towards hopelessness or impulsivity? Does that individual use substances? Has that individual previously attempted suicide or had a non-suicidal self-injurious event? And then is that person a victim or a person who's experienced violence, or is that person a perpetrator of violence? Both of those things are individual level risk factors.
Yeah, and there's
So
definitely a lot of data that says that both people who experience victimization and perpetration have a higher likelihood of engaging in suicidal behavior.
And so when we think about then relationship level factors, what do the relationships that individual is in, look like? And so not just relationships that are occurring, on a romantic level, but all of their relations, familial relationships, friendship relationships, relationships with supervisors. And so when we find that relationships are full of either conflict, violence, isolation, or turmoil, these are all, big risk factors for an individual maybe committing suicide. Or engaging in suicidal behavior. The other thing that we might, that we want to think about is, is there a history of abuse or bullying within that particular relationship? And then what does communication look like and the communication skills that an individual has? What does that look like? And then we want to think about the community. So does the individual have connectedness to the community that they're in? Does that individual have access to healthcare providers or medication? Does that individual have access to mental health providers? A lot of times people's entrance into mental health care is connected to their ability to access medical care. And so, having the ability to have a medical home and then be able to gain, have trust within that medical home, and then be able to be referred to the right resources that may be able to address a mental health concern, extremely important. What is that individual's kind of cultural or religious belief that, is mental health something that's taboo, or is mental health something that can be discussed openly? Can other people in their community know that they are engaging in mental health care? Is that individual living in an under-resourced or marginalized community? Is that community one that may have things that would cause trauma or exposures to trauma or other violent acts? Those are going to be huge risk factors for suicide. And then finally, when we think about the societal items that are there, so there is a lot of stigma around having a mental health concern or mental health condition. And that as a societal, on a societal level, leaves people with a feeling of hopelessness occasionally when they're struggling with their mental health. Portrayals on the media of suicide in an unsafe way. So a sensationalization of suicide, but also, kind of thinking about suicide as something that is only done by a particular type of person, or, a particular caricature of a person can be very unsafe. How as a society do we allow people to have access to lethal means of suicide? Locations that have, more restrictive access to deadly weapons have lower rates of suicide. And so we want to make sure, so access definitely plays a huge role, and availability is a part of that access. And then finally, kind of thinking about all of the isms that, exist in society: racism, ableism, homophobia, discrimination that's related to these, and then government policies that then become attached to these various isms.
And so
okay.
Go for it, please.
When we think directly about youth, one of the things that we, think about is, thinking about kind of the connection between suicide and other forms of violence, and then suicide and adverse childhood experiences. So what happens in childhood is the building block for, what will happen later on in adolescence and then subsequently in adulthood. So, forms of violence that may be experienced by young people could be abuse and neglect. It could be bullying. It could be peer violence, dating violence, intimate partner violence. And then when we're thinking about adverse childhood experiences, these are all places of disrupted transition. So experiencing homelessness, experiencing living in a household with adults who struggled with their mental health, used substances, or had other forms of instability, and then violence within the home unit, whether it be interpersonal or kind of external from a community factor. So as you can imagine, if the things that we mentioned before are things that are risk factors, then there are going to be several things that will help buffer and protect against that. And we consider those things to be protective factors. So some of the protective factors that have been identified is having good problem solving skills, having coping skills, having a moral objection to suicide, having strong relationships. One of the things that I ask every patient that I see, regardless of why they're seeing me, are who are the people that they consider their network of go-to people. Because when a person is in crisis and is really struggling with their mental health and is feeling unwell in that way, that's not the time that they're going to be able to problem solve and identify who are their resources. Those resources need to be identified beforehand. So having, the ability to recognize, 2 or 3 supportive individuals in their life is a very important attribute for young people in terms of protection. And then connectedness, which a lot of times those identities lean in and connect to connectedness. And then reduced access to lethal means is very critical in being a protective factor.
And that's going to come up over and over again as we go through this in terms of how do we manage, how do we prevent suicide, reducing access to lethal means of self-harm. So the question that often comes up is, what about social media, and what is the role that social media plays with young people in particular in suicide? Now, interesting, as we pointed out in the Q&A at the outset, that the CDC noted that the rates in America of suicide remained stable for a 7-year period from about 2000 to 2007, and then a massive increase. And if you track what was happening in America, we know that MySpace, your first friend was Tom, that was 2003. And then Facebook was around, but September 2006, Facebook opens up its platform to everyone who's 13 and older. And they had less than 1 million users in 2004 and bloomed to 700 million users by the end of 2011. So Facebook opens up for everyone. You ran home from school, you got on the computer, you are on your device at home until June 2007 when the first iPhone launches. And now all of us have access to social media on a platform because your BlackBerry didn't really support it. Some of you don't know what a BlackBerry is, don't worry about it. Instagram shows up in 2010 and breaks all social media records by adding 10 million users in the first year. And so at the time that we're seeing these increases in suicide, we're also seeing a vast proliferation of social media, which has led to the question, like, what is the role? But the findings and the data are really mixed about what role social media actually plays. And so back in 2012, this group presented something in the American Journal of Public Health that really describes some of the ways that screen, internet, and social media can increase suicidal behavior, including, for the first time, a generation of young and old people had access to websites that provided education, not this kind of education, how-to education and tutorials, while at the same time having a marketplace to access lethal means. They talked about how the proliferation of social media and internet led to rooms, sites, forums, groups that foster pressure to die by suicide, where people are encouraging other people to end their lives, where they're idolizing and glorifying suicide and people who have died by suicide, where they encourage suicide pacts. There's also good data around suicide contagion, which is this idea that one suicide death can actually trigger suicidal behavior in those who are susceptible, who learn about the suicide. And of course, the exposure to cyberbullying. And it's easy to just conclude that cyberbullying leads to suicide, but the data does not suggest that. The data suggests and continues to suggest that it is almost never the sole predictor of suicide for young people, but being cyberbullied can increase the risk because it amplifies my feeling that I'm isolated, I'm alone. It amplifies instability and hopelessness for those who had underlying pre-existing emotional, psychological, and environmental stressors. More recently, the Journal of Youth and Adolescent 2021, a group from BYU does a 10-year study, longitudinal study, looking closely at the role of social media, and the reference is right there on the slide. And they really showed some nuanced findings from this longitudinal study. They noticed that for boys, social media use had little effect. But boys who were bullied when playing online games, that increased suicide risk. For girls, social media on whole didn't seem to increase suicide risk, but girls who had a high amount of social media use at the onset of adolescence and then increased their use over time, those girls in particular showed a much increased risk of suicide as they entered adulthood. They also found, interestingly, that for girls, playing a lot of video games was the strongest predictor of higher suicide risks for all the things related to media and screens. They highlighted that social media does have some protective benefits, particularly for those who didn't have a high level of use and then increase that level through their adolescence. And so there's a question of, was there a pandemic effect? There was absolutely a pandemic effect from all the data that we're seeing. And so we see that during 2020, mental health related ED visits increased 31% relative to 2019. In the summer, they jumped 26.2 relative to summer 2019. And during the winter, it jumped 50% relative to 2019 winter. While for girls, that is, because there are some gendered findings that we're seeing. And so one of the resources that we're sharing with you would be this resource, which is the Surgeon General's Youth Mental Health Crisis Advisory, highlighting some of this. And it's a really good resource. I think we're sharing with you with the content of information packets of information that we're sharing. So we want to talk about, like, what are some of the warning signs?
So when we think about warning signs, we spend a little bit of this last bit of time talking about youth, but the reality is that these warning signs are important in significance across all age groups. So, first of all, just thinking about Maslow's hierarchy, the things that are on the very bottom of the hierarchy are our basic needs. And when our basic needs are not met, that can be a very good indicator of mental health distress. And those end up being warning signs that could point towards suicide. So eating and sleeping, very important. Another thing that you can kind of think of asking every single patient or client that you meet is really, how are they eating? How are they sleeping? Big changes in eating and sleeping habits are, a very significant warning sign. Then thinking about behavior. So do behaviors suddenly start to vacillate on an extreme? So extreme withdrawal or extreme active behavior that is now violent or rebellious or severe in some way that's atypical. Persistent boredom or difficulty concentrating, a drop in the quality of schoolwork or performance on their job. And then thinking about substance use or running away as being two big indicators that, suicide could be very imminent for this individual.
For young people, absolutely, there's a really strong relationship between alcohol consumption and suicide behavior.
And then, kind of thinking about things that you're noticing just, when you're seeing an individual. So a sudden change or, neglect in the appearance of that individual, their personality, and then kind of now starting to think about, physical concerns. So physical problems that, there isn't really a somatic origin to, or an organ origin to. I always, challenge that terminology of not real. And that's just because, I always say that things come from two sources. They come from either the organ or they come from the mind. And so, for instance, if you're nervous, your heart starts beating faster. it is real that your heart is beating faster. The challenge, however, is not coming from the organ of the heart. It's coming from the output from the mind. Focusing on themes of death, thinking about, looking at what a person's reading, writing, consuming, but also producing. When they're producing things that have themes of death, that's a concern. Giving away prized possessions, talking about suicide, making a plan, even if it seems like it's said as a joke or threatening to attempt a suicide act. There was a thought before that maybe these were things that were quote unquote gestures and therefore not serious. We now know that that is absolutely incorrect as a thought process, and that these are actually very significant warning signs.
Absolutely. And when we speak to parents and work with parents, we say, if your child is joking about suicide, ask serious questions about that joke. Because no one jokes about suicide unless the thought of suicide had entered their mind. And even though they might not be actively contemplating suicide, the idea that this has come to their mind means that I ask serious questions whenever any young person jokes about suicide. And so to try to put this all together, Thomas Joyner published this book back in 2005 with the Interpersonal Psychological Theory of Suicide that I think really tries to pull a lot of what we've been describing together. And the book is Why People Die by Suicide. And the theory proposes that someone will not die by suicide unless they have the desire to die and the ability to do so. And as he lays out his theory, he says that there are two psychological states that must be held simultaneously that contribute to the desire to die, and that is perceived burdensomeness, along with a sense of low belonging or feeling alienated from those that I should be closer with. But even for young people who feel like they're a burden and don't feel like they're connecting and feel alienated, that desire to die is not sufficient to ensure that there will be a suicide attempt. The third element must be present, and that is I have to acquire the ability or the means to enact lethal self-injury. So that burdensomeness, what does that look like? The view that my existence burdens my family, my friends, society. People will be better off if I'm dead. I don't know why I'm here. I just make everyone's life miserable. I just cause problems for people. That's a sense of like perceived burdenness that when combined with the experience of no one gets me, no one understands me, no one sees my pain, no one seems to care. People seem happy, they're just living their lives, not even notice what I'm going through. There's a lot of research that shows us that that feeling that I don't belong combined with burdensomeness is implicated with suicidal behavior. Because what I'm doing, as Joyner describes in this theory, is that I am fighting myself because I have an instinct for self-preservation, and often a suicide attempt occurs when that instinct for self-preservation gets defeated. And so we see, for example, that those who had past suicide attempts experience more serious forms if they have a future attempt at suicide compared to those who had no history of past suicide attempts. And so we want to talk a little bit about, well, how do we manage the crisis of suicide? And there are some resources that I want to share with you. If you're not a pediatrician, the third resource you might have some difficulty accessing unless you make friends with a pediatrician. But the first two are public domain, and they're highly helpful resources. And even though you might not be working in an integrated care setting, the information is just so valuable. And so the Suicide Prevention Resource Center's toolkit and then the SAMHSA's toolkit, which pertains to schools, are both really helpful resources that we want to share with you.
So one of the things that we want to consider when we're thinking about management is, first of all, we want to make sure that everybody in our staff team is trained to recognize and respond to warning signs of suicide. There are so many times in my clinical experience that the person who gets the nugget of information that's most important for me to intervene in a patient's life comes from my MA, comes from, my nurse. And that sometimes is because when people are in a space of vulnerability, they may share with the person who they view as being less in authority, because that person may appear more relatable. And so it therefore is really important for everybody on the team to recognize and know how to respond to a warning sign, or at the minimum to know when to share a warning sign. Additionally, kind of pointing back to that universality, you want to screen every single patient for depression, and you want to screen every single patient for suicide risk. You want patients, and I would say any other family members or caregivers when you're thinking about youth, to also be educated on the warning signs for suicide. And then finally, when we're thinking about management, we then, are thinking about safety plans and other ways to restrict means for lethal self-harm.
Absolutely.
So, sorry. Go ahead. So a lot of times, we think about, when we're thinking about, other kind of general things to think about, patients don't typically immediately volunteer that they're thinking about harming themselves or ending their lives. So we have to be alert for signs, and we have to create that space for that conversation, because, patients pick up on our cues. And so if we seem like we're distracted, we seem like we're rushed, we seem like we're in a hurry, then the patient may not, go ahead and, share the disclosure because they're not prepared, they don't think we might be prepared to handle that information. We always want to take strong warning signs seriously. So anytime that someone's threatening to hurt or kill themselves, they're talking about wanting to hurt or kill other people, they're looking up ways to kill themselves, they're seeking access to firearms, pills, other lethal means of ending one's life, you want to make sure that you're taking that seriously. Anytime someone's talking about feeling hopelessness, you want to make sure that that's happening. The Joint Commission, again, recommends universal screening. You'll hear us say several times along the way about, talking about universal screening. And then finally, you want to make sure that you're asking the question directly. You don't want to say something like, you're not thinking of hurting yourself or killing yourself. You want to just directly say, are you thinking of hurting or harming yourself? If so, when did you last think about that? How did you plan to hurt or harm yourself? We want to ask very direct, unambiguous questions.
I know that sometimes when I'm working with families or even professionals, we were socially primed and socialized to not ask questions like, are you thinking of killing yourself? Because, whoa, if I use the word killing yourself, maybe it'll plant a seed into the mind of someone who was not previously suicidal. But there is so much data out there that says asking the question will not make a non-suicidal person become suicidal. But asking the question frankly and directly gives you your best opportunity to have someone who is in fact thinking of killing themselves to let you know that they're thinking about that.
So, once we kind of have done, kind of our assessment that there is concern, then we need to establish what is the level of risk. And so one of the first steps in thinking about the level of risk is thinking about what are the warning signs or risk factors that are there, then thinking about what are protective factors that could be present, asking about, exactly about the plan, and then assessing that plan from the standpoint of, are there thoughts? Is there a plan? Is there an intent? And then is there the means to do it? Because, as Dr. Harrison, mentioned earlier, it's the intersection of the thought combined with the access that leads to death by suicide. And then finally, the last step is our clinical judgment. So, what is the next step that we're going to do? Who are we going to notify? What safety resources are we going to put into play?
Absolutely. And so we want to just share with you these tools that I'm sharing with you. We actively use them in our clinic. Like I said, I work in an integrated clinic with pediatricians and nurses and social workers. And this tool, which we've included for you in the list, there's a packet of resources, and all of these resources are in that packet. So because of time, I'm not going to go into all of the tools that's kind of beyond the scope of tonight's workshop, but there are 4 simple questions. In the past few weeks, have you wished you were dead? Yes or no? In the past few weeks, have you felt that you or your family would be better off if you were dead? Yes or no? In the past week, have you been having thoughts of killing yourself? And 4, have you ever tried? If the answer is yes to any, then we ask the following question: are you having thoughts of killing yourself right now? Every adolescent who comes into our clinic for every visit receives the ASQ as a part of routine care. They come in for their yearly physical. They get not just the ASQ, but they actually get the PHQ-9. And the PHQ-9, the patient health questionnaire, has these 9 questions, and it is a depression screener. Depending on the results on the PHQ-9, and we've included that in the packet of resources, so you will have access to all of these tools at the end of tonight's presentation. Depending on the question, the way that they answer these screeners, we ask, how difficult does it make it for you to do your work, to take care of things, to get along with people? And the pediatricians in the clinic, they know that, hey, if this score is above 9, we need to take some action. Often they will bring me into the visit as a psychologist in the clinic to engage in what we call a warm handoff, which is a warm body in the room. So you introduce, to demystify and destigmatize mental health intervention. I just get pulled into the room for an adolescent who has a PHQ-9 of 9 or above. And below, they'll provide them with information and just let them know and do some general things. So those are 2 screening tools. If the PHQ-9 is high, there's the group who created this, the Columbia, and the Columbia goes much more into detail to understand the things that Dr. Gordon just explained about the intent, about the plan, about the means, about the supports, about what makes life worth living. So the Columbia, everyone does not get this, but for those who have an elevated PHQ-9 in our clinic, and I should also say that all of these measures are embedded into our electronic medical record, and so that every provider has access to them whenever they're on the screen in the clinic room with that patient. They never have to leave the room to go and find them. We can deliver them directly to the patient in the room. So I've also given you a copy of this, and I'm just going to pull the slide down so I can pull it up. This is the suicide assessment 5-step evaluation and triage, and it's just a way that we assess. We're looking at all of these. We're looking at the risk, the protective, we're asking the questions, and then we're assessing risk. So let me get back to. Okay, and for those who have risk, then it's going to be really important to engage in some safety planning. And this is an example of the Brown and Stanley safety plan. Brown and Stanley are both are 2 of the creators of the Columbia that I showed you before. And so we want to help young people figure out, like, what are those warning signs? What are the thoughts? What comes to your mind? What is the mood? What situations tend to trigger this for you? How might you tell that you're going to be in a crisis? How do you cope? Coping is such a big part of suicide prevention. Who can you reach out to provide distraction? Who do you trust? Who can you ask for help? Let's write it down. And if you are having a crisis, where are your contacts? And then we make a plan for making your environment safe. And the last thing there is, what makes life worth living for you? So if I'm going to engage in a safety plan, this is what a safety plan might look like. We want to quickly go through a couple of vignettes just to give you an example. First vignette is a patient of mine, and the family afterwards gave me permission to share the details, and we actually wrote this up as a case report, and so it is published. I'm not violating any trust that a family has placed in me. You can also find this in the contemporary issues in pediatrics, CC, I forget the IC, in a pediatric psychology journal. So we're going to call him Earl. He's 13. He's a Black male, African-American, well known to the clinic. He's been coming to the clinic all his life. So the family calls the clinic at 8 o'clock. Why this matters is that there's an after-hour service so the phone lines switch over from the on-call nurses that you get in the middle of the night into the clinic, and it's an automatic switch. And when the phone lines switch from the on-call nurse to the clinic staff, the phone rang, and it was stepfather, who says, Earl has a cold and fever. They look through the schedule, they give them a 9:50 appointment, and the family was at the clinic by 9:17. This is a training clinic, and so we have medical students who see patients before the attending physicians see the patient. And so the medical student evaluates, then the pediatrician evaluates and says, I think that someone has a URI, upper respiratory viral infection. And then stepfather says, can you talk to Earl alone? So pediatrician says, of course. He's been his pediatrician for 13 years. And then he says, oh, I tried to hang myself last night. What happened? I got mad at my mom and I couldn't take it. She yelled at me. She took my phone and she took the money that I had. And so I tied my thermal underwear, the pants that I had on, around my neck, and I hung myself from the gas pipe in the basement laundry room. And it was only at this point that the pediatrician realized that he had not made an examination of his neck, and he noticed that certainly Earl had burn marks around his neck. He says, I didn't really want to die, but I didn't know how to get my frustration out. Stepfather says that the night before, he heard a banging on the laundry room after Earl was supposed to be asleep. He goes downstairs and he finds his stepson hanging. He is foaming at the mouth. He had urinated on himself. He was kicking because his legs were like flailing, and he was conscious. And so stepfather quickly cut him down, but the family did not call 911. They brought him to their room. They had him sleep on the floor, and they monitored him until 8 a.m. and they called the clinic the first thing that morning. So being integrated, the pediatrician reaches out to me, and I have patients on my schedule, and I said I could see them at 12:30. So from 9:17 to 12:30, Early's now sitting in the waiting room being monitored by a medical assistant. He's open, he talks to me, he's non-defensive. He says, I've never tried anything like this before. I've never tried to kill myself. But he did say, I have some anger problems. And he says, I actually kind of want to go home. I'm tired. And yeah, I promise I'll be safe. So we contacted mom. She could not get off work. She had to go to work. Stepdad had the ability to bring him in. She gave us some more history, told us about his background. And as I looked at the medical record, I certainly saw that at the 2-year-old physical. And since then, mom had been saying he's really impulsive, he's really hyper. He had been diagnosed with ADHD. They didn't call 911 or the crisis line because this family has not always felt respected, listened to, or valued in our healthcare system, but they trusted their pediatrician. And as a Muslim family, and mom wears full garb, she knew that she had a sense that I can bring my child here, but I don't know what's going to happen if I call crisis. The family was afraid that the state was going to come down with like a CPS, a protective case against them. And it just speaks to the complications of the medical system. So we worked together, the family and I. I recommended that he be transported for inpatient admission, only for observation, because he was telling me whatever he could tell me as far as I can do in my clinical judgment, just to go home. Mom and dad did not feel real comfortable about bringing him there, but both myself and the pediatrician finally convinced them. They're like, well, he's met you. Why can't he just come and work with you? We'll make it to therapy here. And I was very willing to work with him, but not in that moment of crisis. And so we convinced the family. I contacted the inpatient psychiatric facility. The family did not want to take crisis transportation. Again, their trust is low for the healthcare system, but their trust is high for their pediatrician. So they said, we will take him, and we agreed because he needed to go. And mom did reach out to both of us to confirm that he arrived and he had been admitted. And what I learned from this is, in cases where I'm not feeling comfortable, I'm going to err on the side of safety. Families might not always love that, and there certainly is a long history of disparities in who gets admitted and how people get treated based on your race. But in that case, I wanted to err on the side of safety. It was really important that we had those collaborative relationships. If this pediatrician did not have a psychologist embedded in the clinic, it would have much delayed the process of getting Earl where he needed to be. So important to restrict lethal means, but he found a way because impulse caused him to just take his pants off. But we know that had that home had access to a gun, Earl would not have been alive, because that same impulse would have caused him to use a much more lethal form. And so we were fortunate that they did not have guns and ammunition at home. We need to cultivate the resources and then be aware of all the cultural dynamics that are at play while we're still committed to working towards safety.
So for this vignette, we're going to consider another patient who we'll call Trevor. And so Trevor was a 16-year-old who presented to our adolescent medicine clinic for gender affirming care. When he presented to the appointment, he came with his dad as well as an aunt who was a nurse. He has a past medical history that's significant for an autism spectrum disorder, as well as generalized anxiety disorder. He's not had any past surgeries, and in the family history, his dad also carries a diagnosis of depression. So in adolescent encounters, one of the things that we do is something called a HEADS, which is kind of a structured, more in-depth psychosocial assessment. HEADS can range anywhere from, 15 questions at the most basic form and can extend out to 80, 90 questions in their more complex form, but it's a screener. And so some of the salient things from Trevor's HEADS exam was that, they lived in an outlying county. He lives predominantly with dad. Mom has been deceased for the past 5 years. Grandmother lives down the road, a very integral part of the family in that sense. He was homeschooled starting during high school, and that was because he experienced a large amount of bullying during middle school. Due to the homeschooling, he was no longer receiving services that, kind of helped manage his autism spectrum disorder and how, and the interface between that and education. In terms of activities, really enjoyed video games, but also very creative. And so very involved with creating artwork as well as music. In terms of diet, he's vegetarian and he was the only vegetarian in his family. In terms of substance use, he denies using any substances. In terms of sexual orientation, he was unsure of his sexual orientation and had no prior sexual experience. And then the last S in HEADS we usually call psychology with an S, so kind of to keep it nicely alliterative. And so he had an allied therapist since his mom's death. He first came out to the therapist regarding his gender identity, but was experiencing significant anxiety with agoraphobia and panic attacks. While these symptoms were improving with the therapist felt that there was probably some interplay between his gender identity and the agoraphobia and panic attacks that he was experiencing. So I think, I want just kind of, if you've got a second, trying to drop into chat some of the things that you think might be big risk factors, when just hearing about Trevor and this young person kind of presenting kind of for the first time in clinic.
Sure, use the chat if you can to share your thoughts. What are some of the risks? As we talked about risk factors so far, think about those 4 levels: individual, relational, community, societal.
I'm seeing a lot about his gender identity. I'm seeing stuff about the history of bullying around grief and loss. Sorry, we can go back a slide, Roger.
Lack of mental health support.
Mental health struggles along the way and dealing with grief, the LGBTQ plus society, and limited social network, social isolation, absolutely. So for sure, you all hit on a number of the risk factors. Some additional risk factors that I would include would be, kind of the kind of idea of living in a rural environment versus, a more urban environment. So the outlying county, thinking about I'm based in Florida, and so Orlando is is considered an urban hub in Florida, but some of the other counties around it are definitely much smaller populations, much more of a your parents went to school with the same people who teach you in school, so forth, which creates a different kind of culture in some ways. And then, just kind of, some of the kind of intensity of the mental health concerns that he's having. So when we think about, kind of what happened in his terms of his clinical course. So one of the things that we did for him was first finding him a secondary gender-focused therapist. And so he had really good therapeutic alliance with the therapist that he'd had for all of those years. But, that individual was allied, but really was not comfortable helping carry this individual through kind of some of the questions and things to consider if one is going to consider cross gender affirming hormones. And so he had a secondary gender focused therapist that he met with for 6 months. He, after that 6 months of meeting with that individual, he was approved for gender affirming hormones. In the time course of that approval happening and then being ready to start hormones, dad ended up actually being trespassed from the clinic due to making some threats towards some of the scheduling staff. Aunt got a prolonged kind of travel assignment that was three states away. Aunt was a very integral, almost mother-like figure in this young person's life. But we did start seeing him in clinic. We were able to start the gender affirming hormones, and Trevor actually successfully learned how to self-administer the shots for testosterone. And then in the midst of that, the pandemic started. And so typically patients who are receiving gender affirming care usually will see me quarterly when we look at labs, and then we'll think about doing medication adjustments at that point. But those medical visits had to be moved to a virtual visit with care conferences that happened between his therapists. And part of that came from that since dad was trespassed from the clinic, aunt was the person who would bring him into the visits. But once aunt got the prolonged locums assignment, then that meant that aunt couldn't bring him in anymore for the visits. And so grandma became the person who was doing that. But because grandma, lived far away, because they lived a little bit distant, it required getting on a highway, and grandma was extremely terrified of driving on the highway. And so coming to the appointments and driving was a stressor for grandma, and then subsequently because of that, a stressor for Trevor. So we moved to a virtual visit, and grandma was also worried about her COVID risk, at that time too, with, in the care conferences with the therapist, because therapists got overwhelmed during the pandemic, got spaced out further. But at each of the visits that Trevor had with me, he brought up frequent concerns about the cost of his vegetarianism in the context of being an individual who was on testosterone. And the reason for that being that, testosterone increases metabolism, and Trevor was already slight and built. And so Trevor, one of the things that we had to do was watch Trevor's weight closely to make sure he was maintaining an appropriate weight. And he was really concerned that, some of the textural concerns that his autism spectrum provided him with and sensitivities that, that limited the foods he was open to trying. And so he had very specific brands of, kind of vegetarian meat substitutes that he liked to eat, but they were costly, and he was the only person in the family consuming those. So he would bring this up to me in visits, every single visit without fail, kind of, did I think he was getting enough protein in? Did I think he needed to increase his amount? Could he go to 1.5 burgers and things like that? So the reason why I bring that up and I spend the time on that is because, unfortunately, one of the quarterly visits, we got ready to do our check-in, and we called the family, and we were informed that, unfortunately, Trevor had died by suicide about 3 weeks prior. And so in debriefing with, the therapist team that, we, were conferencing regularly, we had to kind of think through, what were some of the contributing factors that potentially might have led to Trevor's cause of death. And so, just thinking through, I want just again kind of dropping in chat, what are some things that kind of stand out to you? Kind of thinking about some of the things that we've heard about. So I'm seeing a lot about isolation. I'm seeing a lot about burden, and I'm seeing a lot about kind of connectivity and loss of support. And absolutely, those were kind of the dominant themes that, came out kind of in our debriefing. And so, what was interesting was that while Trevor expressed to me a lot of concern around burden in terms of his vegetarianism, he separately expressed a lot of concerns to his therapist around burden in terms of needing to go to the, sessions on a consistent basis. And so, but because, it was kind of something that from the therapist perspective, something that teenagers do frequently sometimes mention, gosh, I don't know if I could come more frequently. I don't know if, I have to do that. Frequently parents do have to pay out of pocket for one of the therapists if their child has to have two, or sometimes both therapists. It's a common concern that that individual heard. And then similarly, I also hearing, kind of the vegetarianism, that is also something that frequently comes up in the context of adolescent medicine, and young people do sometimes express concern over. But collectively, those were two big burdens. Then we think about the loss of context of being in the pandemic and socialization, the loss of his aunt, who was a huge support, and then, where that took kind of coming to medical visits, and then also therapist visits, because, grandma was also driving to therapist visits with the same concern, because there was a briefer period on the highway, but still of this highway drive. So all of these kind of scenarios where, Trevor felt like he was a burden to his family. He was a burden in his community. He had experienced, kind of ostracization from his community, and from others who, knew the family based on his gender identity. And so unfortunately, as unfortunately the statistics do show us as well for the risk of harm and death by suicide in LGBTQ youth. For Trevor, this was unfortunately a scary situation. So I think that leads us to kind of thinking through, so how do we prevent suicide? Because, none of us want to have patients like Trevor in our practice panel. We want to prevent as many individuals from dying by suicide as possible. And so, one of the things that's very important is thinking about how do we respond to suicide? So you're actually
I'm going to play a video for about 4 minutes. This comes from the Mayo Clinic, but you can also find it yourself. So it'll be about 4 minutes.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy. I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual...
Acting really down, crying all the time for no good reason.
Or getting really mad. Not able to sleep, or sleeping too much.
Shutting her friends out or giving her stuff away.
Acting reckless, drinking, using drugs, staying out late.
Suddenly not doing stuff he used to love.
Or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed.
Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself. It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish he'd said something.
I wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask.
They want somebody to care.
Maybe you're afraid you'll make it worse
Uh-oh.
if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask.
In fact, the best way to keep a teenager from killing herself is to ask, are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes.
Well, here's what you don't say.
That's crazy.
Don't be such a drama queen.
You're making too much of this.
That boy's not worth killing
Yourself.
over.
That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself.
What you do say is,
I'm sorry you're feeling so bad. How can I help?
We'll get through this together.
Let's keep you safe.
A lot of people think about killing themselves. Adults and kids.
most of them never try it. but some of them do. So if your kid says,
I'd be better off dead.
I can't live with
I'm
this.
gonna kill myself,
Take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Sometimes kids want to kill themselves because something happened. A breakup, a failure.
But sometimes it goes deeper, and it's not going to go away by itself. Get some help. Talk to your doctor.
Or a counselor at school.
Or your minister.
but don't just let it drop.
And make sure that your kid always has someone to turn to. Someone he trusts. Make a list together, right then. 3, 4, 5 names.
Put a suicide hotline number on there too.
Have him keep that list in his wallet, so he always knows where to turn.
Make sure your home is safe.
If you have pills she could use to hurt herself, lock them up.
If you have a gun, don't just lock it up. Get it out of the house. The bullets, too.
And one more thing. If you think your kid might be about to hurt himself, don't leave him alone.
Take him to the emergency room.
Call 911 if you have to.
We all have our ups and downs, but sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Ask straight out. Are you thinking about killing yourself?
Don't wait until you're sure. Trust your gut.
Because it never hurts to ask.
And it can make a big difference.
All the difference.
in your kid's life.
So I think, one of the things that, this video really kind of poignantly shows is kind of what are the 5 things that we want to do when we see someone who's in emotional pain. So we want to ask the direct question, are you thinking about killing yourself? We want to think about how, again, are we reducing access to lethal items and places? We want to be there by listening and acknowledging their feelings. We want to then help them connect to where they can get help. And we want to stay in touch and continue connection after the crisis. So when we think about, how do we prevent suicide, we have to think through all of the factors that we talked about at risk. So our prevention strategies have to incorporate thinking about the individual, relationship, community, and societal level. And so, like any other public health challenge, it can be prevented. There's no one strategy that's going to lead to a reduction in suicide. And so when we consider all of these different factors, that's when we get the best outcomes.
Absolutely. And so there's a really, really excellent resource put out for the National Center for Injury Prevention and Control, which is part of the Division of Violence Prevention at the CDC. And we only have a few minutes remaining, but please, use your phone, get your camera out, get that QR code. It is worthwhile exploring. It has lots of good information. But in addition to what Dr. Gordon talks about, it lays out different strategies. We know that it's not enough to try to intervene individually for people who are in marginalized economic circumstances, for people who lack access to mental health care, for people who live in dangerous, unsafe environments, for people who are isolated, for people who don't have coping skills. We might have to think beyond what do I do for this person, to think about the context in which they live. And so if you're a primary care provider, they might want to intervene to treat depression. They might want to encourage patients to cultivate a support network. We gave you a copy of the safety planning resource, so we recognize the signs, figure out how we're going to cope, know who to reach out to, have the information for all the hotlines, and then again, most importantly, we make the environment safe and reduce the access that they might have to lethal means. This is an example of something that's put in an office as a way of helping people who are in the office. In any clinic that you work in, manage that. If a patient presents, who are we going to call? Who is going to help us with safety planning? How do we identify their support person? in the community? What are the numbers for the crisis response lines, the emergency room? And of course, so much of the work that we're doing is documenting. The last thing I want to share, because they asked us, and again, unfortunately, we could not go into some of the details in the prevention package, but we want you to have that. This is another toolkit. I'm going to just pull it down, and it is put up by the Suicide Resource Prevention, and it goes into a number of really helpful strategies and ideas. So I'm just going to scroll here to give you a sense of what's in this resource. How do we respond in a crisis? How do we help students cope? How do we work within the community? How do we work within the media? And really, one of the things that's come up is how do we manage the memorialization of someone who has died by suicide? Because at times, well-intentioned young people and well-intentioned systems end up glorifying the act rather than commemorating the person. And so this is a resource that also does a really nice job in helping schools and helping school systems properly respond after experiencing suicide. And so having said that, I think we're at the place where we're supposed to stop for questions. So we will stop and entertain questions. Oh, they did not see a window I opened. Hang on one second. I can show it. Oh, I did not realize that did not happen. Sorry, I will open that resource. I'll just do it. And while I'm doing that, if you have any questions, this would be an excellent time. This will be an excellent time. I didn't realize that when I pull it down. This is the resource that I was describing. It's After Suicide, a Toolkit for Schools. And what I was highlighting is that the resource itself walks you through how do we respond, how do we help students cope, how do we work with the community, including many different, how do we navigate media, importantly, how do we memorialize, what do we do about social media, how do we address issues of suicide contagion, and for school systems who need to bring someone out. So it's a really, really, really helpful resource to prevent future suicide after a school system has experienced suicide. And unfortunately, all of us probably can share a story about experiencing a suicide within a school and then the aftermath of that.
And so to kind of follow up on that, I think one of the questions in the chat, kind of thinking about resources for information about serial suicides in school districts or regions, that is actually a really good resource for kind of helping school districts prepare for that, because a lot of kind of the suicide clusters are really kind of based in kind of sometimes how the response to the aftermath of a suicide in a community and how that's handled is really what we've found so far to be the biggest predictor for kind of what happens in a suicide cluster. And so by really being able to use evidence-based strategies around how, for instance, suicides are discussed, how death by suicide is discussed in media, how it's discussed when the announcement is made, and then what's provided in terms of aftercare counseling resources for both close bystanders as well as more distant bystanders, is actually kind of very important in kind of preventing future deaths by suicide.
So there are so many questions, and Fatima, I don't know if you want to select questions or if you want me to kind of
Yes.
scroll through
Yes,
and
one step ahead
answer.
of you already. So thank you both. This was a really informative and important presentation. So our first question is referring back to one of the Kahoot questions, and it is, do Alaskan people have higher rates of suicide due to greater access to weapons given their use for firearms as a way of living?
So when we're looking at young people, again, think about that theory of suicide, which is, burdensomeness, isolation, and access. It's never one factor. But think of how many people in Alaska don't live next to folk. Think of how many people in regions like Alaska live isolated, where a simple task as going to the store is like a day trip. I think, that you can consider also the role of, climate, the availability of like sunlight in the sky through like really dark periods of the year when you only get a couple of hours or none, not really any meaningful sunlight during the day. So again, I don't think it's a single cause, but certainly the availability of weapons and all of the things that create isolation and burden seem like more pronounced in Alaska. But we see the same thing, for example, on reservations, Native American like tribal reservations, where the same sense of isolation and hopelessness and access to lethal means exists.
And that's what I was going to say. There's also, when we're thinking about community factors and societal level factors, in Alaska, there is very large, wide disparity between a population that actually is predominantly Native Alaskan and how those individuals live in terms of access and resources in comparison to people who essentially are what they sometimes jokingly call transplanted Alaskans. So people who are not from the Native Alaskan population and are more congregated in the larger cities and have moved to Alaska essentially for work and have additional resources, both in terms of finance as well as access. So yeah.
Okay, thank you both. The next question is, do children and youth with autism or other neurodiversity have an increased risk for suicidal behavior?
Yeah, so Lonna, you want to start with that?
So I was going to say, yes, there is evidence that suggests that they do have increased risk for death by suicide. And it has to do with, again, the accumulation of risk factors. So children with neurodiversity are more likely to have been bullied or marginalized by peers. Children with neurodiversity are also, I think, interestingly, more likely to be members of the LGBTQ community. Children with neurodiversity also are going to sometimes have the perception in their mind that they are more burdensome to the people who help support them, family, teachers, and so forth. And so that can lead to additional kind of feelings of isolation.
Yeah, and I think what I want to do is just, I'm going to share one deck to add a little bit more. What I'm sharing with you here is a modification. This is from another talk, a modification of Pam Hayes's addressing framework. For those who aren't familiar with Pam Hayes, the addressing is an acronym that talks about the important parts of our cultural identities. And so it strikes through our age, our ability status, if we were born with something developmental or acquired a disability over a life because we had an accident or we lost sensory functioning or something else happened where we have acquired a disability, thinking of our religious and spiritual orientation. A lot of highly religious communities, kids who also have, who are non-cis hetero, non-straight kids, but highly religious are at risk. Your race, your political affiliation, your wealth status, but your politics, the way that your body appears, thinking about those who live in larger bodies in a world that fat shames. In every part of this, there are people who are centered and idealized, and there are people who live in the margins. And so to the question of children, youth with autism or autism spectrum disorder, as we think about that as like an ability status, if I pile onto that like other marginalized identities, I might not be kind of like gender normative. I might not have socioeconomic status. I might live in a large body. I might not meet like the white ideal or the light-skinned ideal. So the more of these, it's not really only about the autism spectrum, is that for each of these aspects of our identity that sits in the margin rather than in the center, it tends to increase risk. And so when we hold multiple of these, then the risk increases further. And someone mentioned chronic illness also in the chat, but it's the same thing with chronic illness. I think chronic illness for lots of people, young and old, increases the sense of burdensomeness. And that is why you see higher rates of suicide for those who carry chronic illnesses.
And specifically when thinking about young people, the more physically apparent the chronic illness causes the young person to be, like the more physically apparent the chronic illness is, the higher that burden is. I always frequently jokingly say that adolescents fight really hard for the ability and the right to look just like everyone else. And so, you know, adolescents want individuality, but they also want pure belongingness. And so that is a constant battle in that developmental time frame in life, and it's developmentally appropriate. And so where chronic illness can intersect with that can be quite a challenge, particularly when the chronic illness leads to something that makes that young person physically very different.
Thank you both. And the next question, and still thinking about working with youth, how do you view the role of schools and primary care providers in supporting mental health and suicide prevention? And what tips and strategies do you have for them?
For schools?
Yes, and primary care providers.
Okay. So I think, you know, primary care providers, if they are connected to the American Academy of Pediatrics, they have a lot of toolkits that they have already like put out for risk management and suicide management. So there are resources available. I guess my first thought is please connect yourself with resources. I saw someone else put in the chat, you know, I work within our health system here in the Delaware Valley. Every one of our pediatric offices has psychologists integrated, and now we're working on making sure that social workers are also integrated into the offices. And so for a community pediatrician, I would say reach out and cultivate relationships with the mental health community. And even if you can have like what we call a co-located model, which is I'm opening up one of my rooms to have a therapist, a psychologist, a social worker practice out of my office. We know that integration, that collaboration reduces barriers, reduces stigma, and it increases access. And so for communities, yes. For school, there are also lots of resources out there. The NAS, National Association of School Psychologists, they have resources for schools and for people who work within schools. The resource that I shared from the Suicide Prevention Resource Foundation has lots of real nice practical information and advice for schools. And we might not even have time within the scope of what's remaining here to go into all of those details, but I say first thing is there are resources out there. Find and connect with your resources.
As I say, the SAMHSA toolkit also that you provided at the beginning also is a great resource for schools as well. But I think that step one is definitely, first of all, identifying who are going to be your community partners. And then step two is then preparing staff on the warning signs and then preparing them on how to address if they get a positive screen. Because, you know, it's very important to screen, but even more important than screening, you know, is knowing what to do with a positive screen. And so, you know, making sure that groundwork has been laid. And then the nice thing is that you figure out the toolkit that you like best. All of these toolkits come with forms that you can literally print and utilize, whether at your school or in your office. You know, they're fairly, and they provide very nice instructions on, you know, what is a positive screen, what would be the next step that you would take if there was a positive screen.
Thank you both. So I think we have about time for one more question. So the last question will be, What are the best practices for gender affirming care for transgender teens that help prevent suicide?
So the number one,
I'm going to let Dr. Gordon go because she's in Florida. And I think it's only appropriate to have a Floridian answer this question first.
I was going to say the number one thing that we have found is that the identity of a supportive adult is the number one protective factor. And so, you know, young people, one of the biggest developmental tasks of adolescence is being able to congeal your various relationship statuses. So your relationship to peers, your relationship to family, your relationship to romantic partners. The second most important task of adolescence is actually deciding on kind of what you expect your life trajectory to look like in terms of gaining autonomy and accomplishment in something. And so a lot of times we think of extracurricular activities as being things that we do to get, you know, stuff for a college application or think about a scholarship. But the number one reason that, you know, activities are important for extracurricular activities are important for young people is thinking about positive youth engagement and a feeling of accomplishment at being able to find out something that you are good at, something that you may be less good at or not as valuable in. And then what does that, you know, look like in that sense? And so being able to help support young people in that way is critical. And then thirdly, you know, thinking about then how do we advocate for an environment and a society that allows all young people to thrive? And so, you know, when we think about, you know, some of the legislative policies that are out there, some of the legislative policies that are being threatened. So, you know, definitely states in the South are very prominent, you know, Florida, Texas, Arkansas, Alabama. But the reality is that there are 34 states in the United States right now that have some kind of anti-LGBTQ like youth-directed legislation that is at some phase in, you know, either committee or, you know, something that's actually been brought, you know, before the floor. So in most places that you live, there is work to be done, for sure.
And I will say that because I'm looking at some of the other questions about what do we do as a psychologist, as a mental health provider, as a part of like a medical care team, turns out that one of the most important things I can do for a young person is instill hope. Most people approach the lose that will to continue because they have lost the sense of hope, the sense that something good is going to come. And so it's not just the burden, it's a sense of hopelessness. And so when I hear and I'm doing an assessment, as I'm thinking about the plans, it's not plans for the sake of planning, it's plans with a message that we are going to get you through this. Right now you're in a season. This is not going to be the way that all of your life feels. And in fact, this is what depression is, and this is what depression feels like. You are not depression. You might be experiencing depression in this moment, but if we can treat your depression and get you out of this situation, you will feel better. So it's really important at the end of the assessment, at the end of the safety planning, at the end of the intervention planning to instill hope for young people.
Dr. Harrison, Dr. Gordon, thank you so much for your impactful, powerful presentation. Fatima, thank you for asking questions. This is Fatima's last event with us as a graduate assistant, and we've been so grateful for her to conduct these questions and answers. And Dr. Gordon and Dr. Harrison, I don't know if you'd be open to answering a few more questions with Fatima. We have just a flood of questions that people haven't had a chance to ask. And so we can talk in a minute or two, but we're grateful. This was really hard. Please take care of yourselves.